From the plains to the rolling hills, Oklahoma is a state that resonates with stories of resilience, determination, and pride. Welcome to Inside the 1581, a podcast of the Oklahoma Hospital Association. Together, we'll dive deep into the heartbeat of the great state of Oklahoma as we journey through the rich history, diverse culture, and the ever-evolving landscape within the 1,581 miles of border in our nation's 20th largest state. Each episode of Inside the 1581 will feature conversations with the many voices which help shape our state's future and our shared vision of improving health and healthcare in Oklahoma.
Thank you for joining us for this edition of Inside the 1581. Today we're going to talk about Medicare Advantage. For those of you that may have seniors in your lives, your grandparents, your parents, they're going through this effort right now to evaluate their healthcare options. And certainly every senior is eligible for Medicare, which we call traditional Medicare. And they're also eligible to consider converting to a private health insurance option, which we call Medicare Advantage. And so we're going to talk a little bit about that today. And I'm joined by two healthcare leaders that are members of OHA. I have Chris Wright, who's the CEO and the Chief Nursing Officer for Purcell Municipal Hospital, and Dr. Matt Jared, who is a telehospitalist who works in a number of our hospitals through the SSM system. So, guys, thanks for joining us today as we have this conversation.
Thanks, Rich.
Earlier this week, actually it was last week, OHA launched a website, which is www.medicaredisadvantaged.com. And you can use .org, .net. I think we're actually promoting .org. And the purpose of our website was to provide public-facing information for seniors. I have a mother who's 95. We're blessed to have her for 95 years. And for most of that time, we had her in a Medicare Advantage plan. She was in good health. Ironically, not on any medications at 95. So, Matt, I think that's pretty cool.
It's amazing.
And but she lives in an urban community in Orlando, so she has access to all of the advantages that you would have in an MA plan. But now at 95, and the worry of if she had a fall or a condition and needed post-acute care, would she actually be authorized for that post-acute care? And I think we'll talk a little bit about that. So we've made the decision to move her back into traditional Medicare, just to protect her and to protect ourselves in ensuring that she does get the care that she needs. And so we launched this website. Very good response so far. And it answers the questions that a lot of seniors are asking, like, what is Medicare Advantage? Why is that different from Medicare? And so what we try to share with seniors is that Medicare Advantage is a guaranteed health insurance program for every senior. And if they choose an Advantage plan, there are two options for them. There's a hospital-sponsored plan, and there are private health insurance-sponsored plans. And we know by much of the literature that hospital-sponsored plans tend to really include tight case management. You have physicians, oftentimes employed physicians, that are working in the hospital system right there. You have the connection points for primary care, post-acute care. You have a pharmacy. You have all of the other advantages to an MA plan. But the difference is that it's Main Street focused, not Wall Street. Mm-hmm. And so then we also talk a little bit about, the Advantage plans, because not every community is going to have a hospital-sponsored plan. And so, what are those considerations, in terms of, does that plan offer benefits that's available in my community? And I know in Purcell, you guys you're in a kind of an interesting, a kind of a tweener community, right? You're not far from Norman, but the potential offerings in your community, might be much more limited than what you would have in Oklahoma City. And clearly in Shattuck or in Guyman, or in McCurtain, you're not going to have the same options that you're going to have in an urbanized community. And seniors need to know that.
Absolutely.
And so that's kind of what we did in launching the plan. And so today we want to just kind of talk about real world, what happens in our hospitals, and what does a physician or nurse practitioner go through when they're trying to ensure their patient has the best care? And I know you guys have gone through this experience.
Yeah, we have. Yeah. Definitely often, unfortunately.
It is unfortunate.
To the chagrin of much of our patients' benefit. So, it's one of those things that I'm so glad we're talking about, because people often ask this conversation of me when I'm in a clinic room with them or when we're out in the community talking with friends and family. And my parents are also on a Medicare Advantage plan right now, and so it's something that's very germane to our lives and what they're dealing with. But it is something that's important for patients to realize when they're signing up. This is that time of year when you get that opportunity to sign up, to look, you can change. And it's important to think about, what am I going to need? What am I using? And how can I benefit best for my financial security and my future for my health? Because, we'd all like to get to 95 and be living a long, healthy, wonderful life and pray that it's without medications, without needing extra interventions. But many of us do need those. And how are you going to get that when it's time?
Well, I think one of the biggest challenges I think that we've seen, we can set aside whether or not a hospital is getting paid, and Chris, we'll get into that, but making sure that patient, who's the most important feature in this relationship, is protected. And sometimes it doesn't always come across that way. So let me give you a couple examples. And for our listeners, I really encourage you, if you want to get into this and really understand in greater depth of some of the challenges that are out there with MA plans, there was most recently a report that was done by the Permanent Subcommittee on Investigations. And it's a congressional committee that looked at some of the behaviors of Medicare Advantage plans and looked at really zeroing in, and this is what just jumped off the page for me, was the access and the authorizations for post-acute services. And maybe, Matt, we can talk a little bit about those. But what they found in one plan, I'm not going to name names, but I'm just going to say Plan A, that they were 3 times higher than the company's overall denial rates for authorizations to post-acute. So let's say somebody needs care in a nursing home, and their denial rates, they're denying that access to that care 3 times the overall rate. And it also went on to find out that another plan, Plan B, that their post-acute denial rates were 16 times higher than the overall denial rate. And so for a senior who and their family that is expecting that, grandma or mom just had hip surgery and they need that post-acute care, and now they're being told, you've got to go home and come back in a couple of days for home health, or we'll send home health to you, when you need that wound care and the physical therapy and everything else with it. So why don't we start with that, Matt? First of all, tell me about your career.
Sure.
and your experience in Medicare Advantage.
Hey, thanks, Rich, and thanks for having me on today.
Oh, absolutely.
It's a lot of fun. So, I've been a hospitalist by practice since I finished residency back in 2012. I've worked primarily with SSM and have the wonderful opportunity to do some telemedicine.
Where'd you go to med school?
Now. I went to OU
Awesome.
here in Oklahoma.
Great.
Graduated there and did my residency at St. Anthony Hospital, and that's how I kind of got plugged in there at SSM. So had a huge opportunity to work with these type of issues in the hospital for the last 14 years, really, even in residency some, and now I get to work with some of the smaller hospitals in the state, which is really a huge passion and joy of mine, to be able to see these small hospitals keep their doors open, keep their community served, and help them continue to provide the care they need to and can provide for so many Oklahomans around our state. So that's kind of my practice. That's my history and where I come from. But honestly, the exciting part about having this conversation today is just that it's something that affects so many people, like we talked about before, and it's something that seems to be so bent on creating a system that's not working. We all look at this and say, gosh, this isn't working. We all know there's a problem. We all see it, but no one can really find a solution for it. So how do we talk about it in a way that helps us all come to better solutions for the patients and better care for our communities, and helps hospitals keep their doors open where that care can really happen close to home?
So you've seen this probably in St. Anthony's, and you've seen it in Purcell, perhaps several of the other SSM affiliates. Has there been a different experience between, in an urban community where there's certainly the mothership is there, St. Anthony's, which has market strength to push it back against a health plan that's potentially denying or delaying care versus Newman Memorial,
Right.
or Purcell Municipal.
Well, and I don't want to over talk to you, Chris, but the reality is the answer is yes and no. Yes, it is different, but honestly, they all get treated the same.
Okay.
It's just that the large mothership, if you want to call it that, has a lot more money that they can lose in investing and trying to overcome this before they actually lose money. Smaller hospitals like Chris's out in Purcell, they don't have that ability to hire 14 staff members to staff this out and hit it from multiple angles and trying to adjust to every impact that happens on a really quarter-by-quarter basis as they adjust how they're going to manage these denials or throw more of them at us. And that's really the hard part, is it's so hard to predict where they're going to go next. And that as soon as you figure out how to adjust, they're going to find an adjustment back that cuts your cost or cuts your profit and increases your costs again.
So, Chris, when you're meeting with your board, and certainly you've got the city right there with you as well as your partner in this, as you're looking at your financials, how is that being received by your board, and then certainly city leaders who also may not have a lot of healthcare experience, so may not truly understand, well, why is it that you just can't get paid, by a health plan?
That is a hot topic. The things that we experienced there at Purcell, we've had to overcome a lot of things, especially after the COVID period, and we've dug ourselves out of a hole and moved into a new hospital.
Which is beautiful. Visit your hospital. It's really a great community benefit for sure.
Most definitely is, and we made ourselves profitable in a lot of different ways, bring on different services, and one of them was dependent on inpatient. Well, things have changed since COVID, and so the few patients that we get, we really need those reimbursements, and even in the emergency room, which is very active, and some of our outpatient services. And what we're experiencing right now is where things are supposed to be following sort of the Medicare guidelines,
right,
are not. I mean, it's just a perception, and where through artificial intelligence, and I assume that that's very active because it's almost like you have to go through the denial process 3 times, and the first 2 are almost automatic before you get into touch with a real live person to talk to. And our rates and appeals that are greater than 120 days is just like through the roof with these Medicare Advantage.
Well, and you're not alone. I mean, I have in front of here a readout from one of the software tools, and we'll talk in a second here again about individual patient experiences, but you kind of touched on it, Chris. We use what we call our payer scorecard. So we look at every claim for our participating hospitals, every claim that flows between the hospital and their physicians and the health plan. So just in the Medicare Advantage plans, I went ahead and pulled a quick run of those that are participating in this. And to your point there, we have what's called clean claims, right? And then ultimately the full denial rates. So what we are seeing is that there is a pattern where there are multiple requests for authorization or multiple requests for payment, and you start with a clean claim rate of 80%. That means they go right through, and then you're haggling over the 20%, and in the end, only 2% are denied. So there's this gamesmanship that takes place over that when ultimately it does get paid. So why not authorize it just as Medicare would? And with all of the electronic claims processing should be pretty quick, right? It shouldn't take. We have one health plan here that takes twice as long as their competitor, twice as long as traditional Medicare for you to get paid. So are there games being played? We can all speculate on that, but clearly the information does show us that that they could do a better job in terms of managing those claims.
That's 100% correct. And the thing that I think we notice on the inside looking out is that the escalation of this process has been dramatic. I talked to you about being in practice for 14 years, and when you get started 14 years ago, there were times when you're going to get a denial. There were times when you're going to have to go through the process of appeal, and at that point, it almost made sense. It was almost like, yeah, these are the highest risk, most likely to be wrong, and so we're going to show them that we're right. But as it's gone along, all these are getting overturned as we go through the process.
Right.
But the process gets more and more robust, more and more automated, less and less about the patient and another physician or two physicians having a conversation about, is this medically necessary, and more about, let's just say no and hope they don't come back and ask.
And it's hard for Purcell, it's a smaller hospital, to have
course.
that ability to go back and invest in it. So I'm sure there are many small hospitals that just walk away from it because they've got to move on to another patient. They're a critical access hospital, less than 25 beds. They've got patients they need to attend to, and that certainly does divert their resources.
Yeah, Medicare Advantage makes sure none of this is low-hanging fruit for the hospitals, and that way they can make sure that they keep the dollars in their pockets, I feel like.
Well, and to that point, it was reported most recently by Mark Farah and Associates produces a report annually that looks at the overall gross margin for payers. And Medicare Advantage, for every enrollee, they make $1,982. And so certainly the dollars are there for every enrollee. You're talking 60 million people potentially. I think the number is in Medicare Advantage. So there's a lot of money, and so we've seen the plans benefit from that. But with that, we know that boots on the ground, where you're at, Matt, where you're at, Chris, you're dealing with these authorizations and you're dealing with the denials. So, Matt, we talked a little bit earlier about some of that experience. Give me some examples of, how you approach, seeking an authorization, how you work with the health plan, the frustration that you've expressed to me that you've had, and how do we convey that to a patient? Because ultimately the patient's expecting, am I going to go home? I don't feel ready. Or am I going to go to someplace that will allow me to get the physical therapy I need, the wound care that I need, and any of the other ancillary services that are going to help me recover quickest? Let's talk about that.
Well, it is a difficult conversation, and I think a lot of us think about those conversations with our family members primarily when we get into the moment. We don't think in advance, and so it's hard to have that conversation just in such a difficult time when someone's suffering in front of you. But you have to, and what you have to realize is that these opportunities for recovery are limited. There are only so many inpatient rehabs, only so many skilled nursing facilities, and so there is a bed issue there that we have to consider. But in reality, most of those facilities are not overbooked. Most of them are not full all the time. Maybe during COVID there were periods, but for the most part there's availability. And so if there's availability, what patients need to go? And I think as physicians, we see all the time patients that come through the doors, and you can just tell they're not getting better as well as we'd like. They have, because of their multiple comorbid conditions, a little bit more need for a little bit longer recovery or a special condition, and we try and find that opportunity for them. Unfortunately, when you see this roadblock ahead of you, you have to warn the patient in front of you, the family that's talking with you, that this is not going to be easy. We're going to end up sitting here for a while waiting. I think we had a patient at Purcell that waited almost 30 days to get a discharge plan put together when we pretty much knew what needed to happen from the day they arrived.
You've probably already developed a discharge plan. You're just trying to get the health plan to sign off on it.
Yeah, we all knew what the discharge plan was. The patient knew what the discharge plan was, and it was just basically me every day coming in and saying, well, we're waiting for the insurance to let us know if we can do what we know we need to do. And that took nearly 30 days for that one patient, I remember. It's a series of kind of related events that seem to come back time and time again to what's costing these plans the most money, so they're going to shut that down, and then we have to prove that these people still need the services that they've always required, always needed, and will likely continue to always need. And in doing so, sure, they probably save some money because it costs us to go after it, and it costs the hospital more. And the hospitals in and of themselves, Chris, I think it'd be good for you to talk about this, but not only do you not have the margin to just continue to put up and put up and put up for it, but you need the profit dollars to continue to reinvest in a hospital so that not only can you get a new building, but can you upgrade the beds that are wearing down from you, so update, all the supplies that you need, right?
No, absolutely. It is something that we're in the mothership, like we were talking about. St. Anthony's has the resources to take some of those hits. we cannot afford to take those hits. We are operating on such a thin margin, and it requires us to be able to do that. I mean, some of the things that we struggle with is such as where Medicare, you don't have to get pre-auths on some procedures. Medicare Advantage, you have to go through a pre-auth, and that delays the patient getting the services, and it also has them looking at other places to go.
Yeah, exactly.
Well, and I would think too that the delay has the potential of contributing to a further erosion of their health status, as they're presented. So you actually have, by the delay, can actually increase the level of acuity for that patient. So I think
Absolutely.
you have that's going on, which is not in the best interest of the patient. The whole issue of patient satisfaction. And so we know that hospital, in how we are measured under Medicare, that patient satisfaction score is really important. And we work really hard to ensure that we have good patient satisfaction scores. And I would assume that this is a dissatisfier when a patient is sitting waiting to either be admitted or waiting to be discharged, like you referenced before, Matt. It would seem to me that creates a whole nother set of issues that can compound further Medicare reimbursement based on patient satisfaction.
Well, and just in their general recovery. I mean, I talk to people a lot about how, we want you to rest while you're here. Sure, we want you to get up and move around, but, a lot of our patients are there because they need to recover. And so we want you to rest when you need to. But when they're trying to rest, but they're thinking about, is this going to get denied? Am I going to get a surprise bill? Am I not going to be able to pay for this? I'm already off work and I can't afford to be, or I've got a fixed income and I can't afford any of these extras. And they're spending their time resting, quote unquote, but worried about all this. They don't have the ability to rest in the way they need to recover and get better in a timely fashion. It also increases the chances that more complications are going to come up while they're there, right? And so all of this compounds on top of the patient and is left on their shoulders ultimately, because they're the ones sitting there concerned and have no real way to advocate for themselves, because it all comes down to me and Chris and others in our community trying to talk to the insurance and negotiate a discharge plan or a covered procedure that they need in a way that will effectively help them get out of a financial burden that they're going to have to endure if no one else will take care of it, right?
Well, and Matt, it's almost as if you're looking over my shoulder at my iPad here, because we did, OHA did a public opinion survey. And what we wanted to be able to do is look at how hospitals are performing and how they're received in their community. And we added other questions as it relates to, health insurance and so forth. And one of the responses that we had, we asked this question. We said, well, here was the result. Whether you agree or disagree with each of the following statements, please select which one you most generally agree with. The results of this was that less than half of the respondents think insurance companies are meeting their needs. Only a quarter say that they put patients over profits. So the question was, generally speaking, do you believe health insurance companies are meeting the needs of people like you and your family? And it was interesting that in Oklahoma, 55% of the respondents said no. Interestingly, nationally, same question asked, 54% said no. So we're right there. We're not a deviation from that norm nationally. And then we asked another question: is health insurance companies are A, most likely focused on making money, or B, most focused on caring for patients? 75% of Oklahomans believe they are most focused on making money, and nationally it was 80%. So not much of a deviation, but clearly the public believes that, and they've probably have been recipients of this. And so we went on to ask another question. And in that question, the results were strong majorities agree that there should be more recourse for prior authorization denials. Mm-hmm. And so the public believes, 71% believe that a health plan should have clear and concise reasons for why care was denied or delayed, and that should be shared with the patient's physician. So with that, Matt, how detailed has been the explanation to you as a patient who's sitting there, in the gap for their patient?
Yeah. Well, I think they've got the concise part down, because it's usually very short, but it's not very clear. You have no idea what that really means. I do remember one instance where it wasn't a discharge plan, but it was really just getting the authorization to admit a patient with heart failure who had flared up. They were overloaded with fluid, couldn't breathe, required oxygen. Their whole body is swollen, and they can't hardly move. And we admitted them to treat this patient, right? The insurance denied the admission, said, no, that doesn't meet criteria. You can't admit that patient. And I called because eventually, I need to do a peer-to-peer, and this is ridiculous. We've got to treat this patient. And I get on the phone, talk with this guy who ultimately approved it in the process of the conversation. I said, this is crazy. This has always been an inpatient admission. This has always met the criteria, and of course it does today. And he said, well, we deny heart failure admissions if, they're not staying 48 hours or more. And I said, or if they're not staying 72 hours or more, I apologize. And I said, really? And he said, yeah. And I said, but you let us know before 72 hours is up. Well, we have a policy that we want to give you an answer within 48 hours. I said, so you can't approve an inpatient admission for heart failure until 72 hours, but you automatically have to give an answer by 48 hours. So you systemically deny every heart failure admission, right? He said, well, we do, but that's not what I'm trying to say. I said, yeah,
that's what you said.
Do. So you're automatically, and this is one of our Medicare Advantage plans that we're talking about today. The one that actually you mentioned takes 2 times as long, right?
Yeah, they do.
At 48 hours, they're going to give you an answer, but they will not give you a yes until 72 hours. So they're automatically going to tell you no every time you come in with heart failure. To me, it's just absolutely absurd. You have to know what you're doing when you create that kind of a policy. You have to see what's going to happen, right? And not only does it increase the workload for Chris and I, it obviously increases the stress and the burden on the patient at the same time. Nothing ends up changing, like you said. 2% is what stands up after all of this, right? Less than a standard deviation is what stands up after all of this of what's changing. And when you think about the profits that they're pulling in and you think about the cost it is to us, really it's just an increased cost, which means a lowered reimbursement. Even if we get paid, it's a lower reimbursement than what we were originally promised in our contract. And it leads to all kinds of mess and chaos for the patient care during their stay with the hospital.
Thank you for joining us on this edition of Inside the 1581. This is part 1 of our conversation on Medicare Advantage. And I want to thank Chris Wright, the CEO of Purcell Municipal Hospital, and Dr. Matt Jared, who is a telehospitalist at Purcell Municipal Hospital and part of the SSM system, for joining us as we talk about those issues that are important to seniors who are trying to make that decision whether to stick with original Medicare or moving on to an option in Medicare Advantage. So as we wrap up this edition, part 1, I want to thank you for joining us today. And I also want to thank some of our team members who have made this possible. Certainly the folks at PYA, which are our sponsors. PYA is a national accounting, advisory, and consulting firm that supports our members in the work that we're doing here at the Oklahoma Hospital Association. I want to thank Alex Taylor, who makes this podcast possible. He is the producer of Inside the 1581. Our director of communications, Susie Wallace, who keeps everything rolling here in our comm shop here at the association. I also want to make sure that you subscribe and follow us to stay up to date. You can do that by checking us out on YouTube and subscribing to that, as well as Spotify and Apple Podcasts. Also want to mention our music track, as we have every week. It's provided by Gunslinger by Ends of the Earth, and we appreciate the use of their music for our soundtrack to Inside the 1581. So until we return again in 2 weeks, where we'll pick up on our conversation on Medicare Advantage for our part 2 on this conversation, we want to again thank everyone for joining us on this edition of Inside the 1581.